Hi, everybody. Good morning, good afternoon. My name is Dinesh Khanna. I'm a rheumatologist and director of the Scleroderma program at University of Michigan. It's a great delight today to talk at the RheumaCon 2021 in Lahore, Pakistan. Sorry I couldn't be there in person, but these are difficult times, and hopefully in future I can visit the place where my grandparents were born pre-partition. Today, I will talk about connective tissue diseases associated lung fibrosis or ILD. Here are my appropriate disclosures. I have two large objectives, and my talk should take about 40 minutes or so from beginning to end. I want to discuss, as a rheumatologist, what are the connective tissue diseases that are associated with lung fibrosis, and then discussion including who to screen and how to treat underlying lung fibrosis. So when you think about ILD, our role as a rheumatologist is largely focused on the diseases that I'm showing on the right side: rheumatoid arthritis, lupus, Sjogren's syndrome, and myositis. But when you think from a pulmonologist perspective, ILD is a very large field, such as sarcoidosis, idiopathic ILDs, which would be IPF, exposure-related ILDs, and other ILDs. When you think about rheumatic diseases, these are the three ones that I will talk about: rheumatoid arthritis, myositis, and scleroderma or systemic sclerosis. And I just want to highlight that there is a lack of agreement and consensus on the prevalence of ILD in these rheumatic diseases. We have to acknowledge that we are all biased. Where we do HRCT, do not do HRCT. Where we do pulmonary function test, we don't do pulmonary function test. And then there might be genetic predispositions that may be different in Caucasians and other ethnicities in US compared to Asia, including India and Pakistan. But these are the three that I will focus on. And you can see there is a theme out here that about 20 to 30% of the patients may have clinically significant and meaningful ILD. And I think the question, if we were doing live question and answers, was to ask whether you see 20 to 30% of your rheumatoid arthritis patients having underlying interstitial lung disease. I have to be honest, I don't think it is that high prevalent, but this is what the data suggests. So what are the few take-home messages? That spectrum of ILD varies depending upon the underlying connective tissue disease. We do not do a diagnostic biopsies. The histology does not help with the underlying CTD. It does determine how the patient will do. And I think that's a very important point, and I will keep on emphasizing it during my talk. If you diagnose somebody with CTD, with underlying ILD, they have a much better outcome compared to if you diagnosed them with idiopathic pulmonary fibrosis. CTD ILD has a better survival than IPF. The only exception is rheumatoid arthritis ILD with UIP pattern. Here's the data from 2004, different ILDs. The top one is a sarcoidosis, which has a 5-year survival of 91%, hypersensitivity pneumonitis, a 5-year survival of 84%, our connective tissue disease, a 5-year survival of 70%, and idiopathic pulmonary fibrosis or IPF, the loner out here with the 5-year survival of 35%. So you have to be aware that our role as a rheumatologist, if there are telltale signs on our physical examination, serologies, and other aspects, are very helpful in the prognostication, what the patient would do. So let's talk a little bit about the pattern recognition. This is what I do on a daily basis in our clinic: pattern recognition. If you see a patient with basal and peripheral reticulation with traction bronchitis, but most importantly, honeycombing, and here's a pathology of a patient who died because of scleroderma related UIP pattern, and you see these beautiful honeycombs that this patient has. This is called UIP or usual interstitial pneumonia pattern. It's called a pattern because it's not a biopsy proven UIP. UIP is more fibrotic. UIP is associated with idiopathic pulmonary fibrosis if there is no underlying cause. In connective tissue diseases, the most common cause of UIP is rheumatoid arthritis and Sjogren's syndrome. The most common pattern I see in scleroderma is a non-specific interstitial pneumonitis, again, peripheral, basal, ground glass opacity, this haziness, increased interstitial marking, traction bronchiectasis. Therefore, unless and until you're very sure about the pattern, you have access to HRCT, I would strongly recommend you to work with your radiologist, your local radiologist, and your pulmonologist as you take care of these patients. I want to talk about, and I would like to encourage my colleagues who are listening to RheumaCon 2021 to do HRCT in every patient who has myositis and patients who have scleroderma. And I'll give you more thoughts about that as the talk progresses. But I want to highlight the concern we all have is about radiation. So if you look at the annual exposure from background radiation in US where I live, it's about 3 millisievert. If you look at the annual exposure in airline crews, it's about 2 to 3 millisievert. When you look at the chest radiograph, it's much, much lower. That's why we use chest radiograph. What is the disadvantage of chest radiograph? It is not sensitive to diagnosed ILD. You do not want a test that by the time you diagnose the patient have significant restrictive lung disease. As I would highlight, most of the ILDs are irreversible. In other words, once you start the progression of the ILD, you cannot turn the clock back. What we do at Michigan is a standard protocol at the initial visit, which is about 2 to 4 millisievert, which is similar to what you see in the annual exposure. I am not recommending annual HRCT or CT. I'm only stating to do CT at baseline and only repeat it if the patients have progression of symptoms or worsening of symptoms. Before we jump into rheumatoid arthritis as a first title, we need to know as rheumatologists how to interpret a pulmonary function test. And it might be very simplified, but I must tell you, most of the rheumatologists in USA do not know how to interpret a pulmonary function test. There are three values for a rheumatologist perspective are enough. The first one is the ratio of FEV1 of FVC to look whether there's any obstructive lung disease. Anything below 70% is obstructive lung disease. The second one is the total lung capacity. Most of the PFTs do not have total lung capacity, so you can look at forced vital capacity. They are highly correlated. A value of less than 80% is suggestive of a restrictive lung disease, such as ILD. And then you look at the diffusion capacity. So these are the three parameters that I look at in my practice and follow closely as I make a diagnosis and also for the effect or the impact of the treatment. So let's go into rheumatoid arthritis and ILD. Like I stated, ILD occurs in different cohorts in about 1/5 of the patients with RA. Again, I am amazed at this data. I don't think I have diagnosed so much rheumatoid arthritis associated ILD, but this is the data that is out there. Who are the people who are at increased risk? Male, older age, smoking history, high rheumatoid factor, active joint disease. I just want to highlight that you may get consultations in a practice, a patient who has positive anti-CCP or rheumatoid factor who's referred to you with ILD and UIP pattern. And the question they're asking you, can this patient have underlying rheumatoid arthritis? Should you be treating this patient with one of your disease modifying agents? Remember that 20% of the patients may have ILD before the articular symptoms declare themselves. The most common HRC pattern is UIP, UIP, UIP. So remember that when you see rheumatoid arthritis, UIP, or if you don't know what underlying arthritis is. The mortality is 3 times in RA-ILD versus no ILD. There's an ongoing registry that we are part of at Harvard University with the prevalence of subclinical ILD. Subclinical ILD is defined as patients who are asymptomatic. A patient comes to you, you do a HRCT, and they do not know that they have underlying interstitial lung disease. That is approximately 20%. So 1 in 5 people in this registry had underlying ILD. Whether they will progress, whether they will stay same, all these data are yet unknown. So this is what I talked about before, that if you have RA with non-UIP, NSIP, and other patterns, your survival is much better than compared to IPF and RA-UIP. So you should be treating an RA-UIP patient similar to you would be treating an IPF patient. And this is another cohort just highlighting NSIP has a better outcome than UIP pattern. So this is how I evaluate a patient. I do a patient who comes to me with connective tissue disease, and we'll talk about that. They have ILD on HRCT. The question you need to ask yourself is, does the patient need pharmacological treatment? Irrespective of pharmacological treatment, you should be giving influenza vaccine, you should be giving the pneumococcal vaccine, you should be teaching them not to smoke if the patient is a smoker, or not to have a second hand smoker, chewing tobaccos, and all those good things should be educational to them. Once you deem that the patient needs a pharmacological treatment, in our practice, we target the underlying immunoinflammatory disease, the autoimmune disease, with immunosuppressive immunomodulatory therapies. I understand the anti-fibrotic therapies such as nintedanib and pirfenidone are not available in Pakistan, but I'm hoping that soon it will be available that can be used, and you can add those therapies, and I'll show you a little bit of data about that. So if you see a patient with rheumatoid arthritis, depending on that, if they have progressive lung fibrosis, their lung is quite progressive, they're getting really short of breath, you can treat them with a taper, a steroid taper of 20 to 40 milligrams over a period of 1 to 2 months. You have to be careful about the toxicity, but you may be able to do that to calm the exacerbation. When you think about the diseases in connective tissue disease that have exacerbation of their lung fibrosis, two of them stand out quite a bit: rheumatoid arthritis and inflammatory myopathy. So those are the therapies that we tend to use. We heard that cyclophosphamide is used quite a bit in Pakistan, and that's what we use. Tend to use quite a bit of mycophenolate mofetil. There are a few case things I want to make, that if you have a patient who's not responding to mycophenolate cytoxin, it's very appropriate to go to rituximab, a B cell targeted therapy. You can also try abatacept, that has been shown to be somewhat effective and had beneficial effects in the previous studies. A key aspect is that was published in a multi-center study in the European Respiratory Journal last year was that methotrexate was not associated with increased risk of ILD. I've seen that our colleagues tend to stop methotrexate if somebody has an ILD. That's not the reason. The methotrexate pneumonitis is very, very rare, and you just have to be aware of that as you're treating these patients. And I will briefly talk about anti-fibrotics. I don't know whether lung transplantation is available in Pakistan. I don't know, but if a patient has UIP and significant ILD, that's the last treatment choice that they have available to them. I will move to inflammatory myopathy and talk a little bit about why it is important, and the autoantibodies play a critical role out here. When you look at the frequency of ILD in retrospective case series, it is anywhere from 5 to 10%, 80% on HRCT, similar to scleroderma. ILD may precede the muscle or skin manifestations in 30% of the cases. Most importantly, there's no correlation between extent, severity of muscle or skin disease, and development of ILD. So you cannot look at a CPK of 8,000 and say this patient will have more significant ILD than a patient with a CPK of 2,200. The most common pattern is cellular NSIP, and we'll talk a little bit about that. So what comes first? Myositis comes first in about 7% of the patients, and then patients over time develop ILD. In 60% of the patients, they are there simultaneously. What's the advantage of that? If they have anti-synthetase antibody, if they have anti-MDA5 antibodies, you can do HRCT at baseline and determine whether the patient has indeed ILD or not. In 33% of the cases, it's the other way around. Myositis related ILD comes first before the patients develop symptoms and signs of inflammatory myopathy. And then there's a small subgroup where myositis or inflammation of the muscles, elevated CPKs, muscle weakness never develops. So again, I'm hoping all these antibodies are available to you in Pakistan, but when you look at these profiles of antibodies, there are anti-synthetase antibodies, Jo1 and non-Jo1 antibodies. There are anti-MDA5 antibodies, and then there are overlap antibodies that we see with scleroderma, PMSCL, U1RNP, and anti-CoO antibodies. Who are the patients who are at high risk of myositis ILD? If you have Jo1 anti-synthetase antibody, the risk of ILD is 73%. That's a very high risk. Whereas if you have a non-Jo1 anti-synthetase antibody, the risk is approximately 80%. If you have MDA5 antibody, the risk is 50%. So what you see out here is that in anti-Jo1 antibody, the prevalence, which is about 25 to 30% in US population, and the other autoantibodies that I've shown you, 1 in 2 with MDA5 or 73 to 81% of these patients will have interstitial lung disease. I hope everybody knows about antisynthetase syndrome and how to diagnose it. It's defined as a clinically homogeneous patient population with fever, myositis, arthritis, Raynaud's phenomenon. The classical sign for the students out there is mechanic hand, says a patient of mine with mechanic hand, and they get this very progressive interstitial lung disease. In those who come to you and you do an antibody profile, a myositis profile, who are antisynthetase positive, we do a HRCT at baseline and PFT at baseline, and then we continue to do regular PFTs in these patients, even if they do not have ILD. I told you 60% of these patients will have concomitant ILD at the baseline visit. Anti-MDA5 antibody, this is a recently developed antibody, and there are a few issues with this antibody. The first one is the patients have rapidly progressive ILD. They are asymptomatic. They usually have amyopathic dermatomyositis, and they have these distinct ulcers over the knuckles. I've seen quite a bit of these patients because they refer to me as scleroderma, saying that the patient has digital ulcers. Well, these are not digital ulcers. These are ulcers where they might have papules out here, goitrons papules that get ulcerated. The patients have high ferritin level, and we tend to do HRCT, and with a very high mortality. So there are two different cohorts. If you're MDA5, almost everybody dies within a period of 4 to 5 years compared to if you're MDA5 negative. So again, remember, if you see a patient with MDA5, which is highly unlikely, you will actually see a patient in rheumatology office. You know, you get called in the ICU, the patient is intubated, the dermatologist gets called, they look at this rash, they call the rheumatologist. So you have to remember what the ulcer or the fingers or the rash looks like to think about anti-MDA5 and really jump on it. So here is the treatment that we give: mild to moderate disease, oral prednisone, severe to rapidly progressive cytoxin, along with glucocorticoids. And then we put patients on mycophenolate mofetil for lifelong. I do not taper off mycophenolate or Imuran as a thioprin in patients with myositis. These patients crash on you. They have very rapidly progressive lung disease. They crash on you. So once you deem it's appropriate to be them on standard maintenance therapy, I just leave them alone. If they do not respond to it, then we are in trouble. I mean, there are patients of mine who are both on rituximab and cyclophosphamide, and every time I try to taper one of them off, they tend to get very sick, and then we do transplantation in this patient population. I'm just showing you the data published that patients who do not respond to your usual prednisone and cyclophosphamide or mycophenolate, we tend to go to rituximab in these patients. And here's some data just to show you patients are declining. You put them on rituximab, and they tend to have stabilization of their lung disease. And here's a patient of mine, anti-MDA5 antibody. I moved to Michigan in 2011. I started seeing this patient in 2012. And this is a forced vital capacity, the lower dark line out here, and this is a diffusion capacity. And you can see this patient had this sudden decline, hospitalized, made the diagnosis, gave the rituximab, improved, gave the second dose of rituximab, did well for about 2 years, and then had this sudden decline. So I tend to, he's on low dose prednisone along with low dose mycophenolate, and I keep on giving rituximab to this patient on regular basis, and he has done well. So this is the pattern that you see in inflammatory myopathy that is not applicable in a patient who has scleroderma ILD. You see the sudden decline. You give them high dose steroids, rituximab, they come back up. They do well, and then something triggers it again, and they decline again. So this is the classical pattern that you see in a cellular NSIP that you will not see in a fibrotic NSIP. I want to highlight tofacitinib. I'm sure tofacitinib is available in Pakistan, but I just want to highlight this letter to the editor in New England Journal of Medicine, which looked at patients who had anti-MDA5A myopathic dermatomyositis, positive ILD, failed other therapies, and had FVC of greater than 50%. Historical cohort 32, tofacitinib, 18 patient. Look at the 6-month survival and decrease in the ferritin. Again, it's a deadly disease. If I see a patient with a myopathic dermatomyositis, I do add JAK inhibitors because I think this data, although it's open label with historical cohort, to me, it is quite convincing in a disease where we do not have much treatments. So let's move to the disease that I see on a daily basis almost, which is called systemic sclerosis or scleroderma. When we do HRCT in every patient, about 70 to 80% of these patients have interstitial lung disease, of which 25 to 30% have progressive ILD. So the question for a rheumatologist is whether they have ILD or not, yes or no, and who among them will develop progressive ILD. I want to highlight it's largely irreversible. You cannot reverse ILD once it sets in. You cannot have a patient go from 90% FVC to 30% or 40%, give them cytoxin and mycophenolate and expect them to go back to 80%. You can see that in dermatomyositis. Compared to myositis, scleroderma ILD is very slow and progressive. Inflammatory myositis is a rapidly progressive ILD. So here are the key differences, especially in patients who have an overlap syndrome. Majority of the patients on biopsy have fibrotic NSIP. You cannot differentiate this. You cannot differentiate this on HRCT. You cannot look at HRCT and say, well, I think this is fibrotic NSIP, this is cellular NSIP. It needs a wedge open biopsy to make the diagnosis. And therefore, there is no role of prednisone in management of scleroderma ILD. This is the biggest mistake I see. People is diagnosed with scleroderma, have ILD, and the patients are started on 60 to 80 milligrams of prednisone. There's absolutely no role of prednisone apart from, I think, the physicians treating themselves with this. So here are some patients, from our clinic, they might have UIP pattern or they might have NSIP pattern. One thing that's very clear is this dilated esophagus. So those are the signs that are telling you that this patient, and here you see the UIP pattern in my patient, here you see some NSIP pattern in our patients. So when does ILD occur in scleroderma? It occurs in the first 2 to 5 years of onset of disease. I must admit it occurs usually almost at the same time I see the patient for the first consultation. In the first 2 to 5 years, they have ILD. And what you see here is that's when the scleroderma renal crisis occur. So if you give this patient 60 to 80 milligrams of prednisone, you're putting them at risk of developing scleroderma renal crisis. The other aspect I want to highlight is that interstitial lung disease is common in both limited cutaneous, also previously called CREST syndrome, CREST, and diffuse cutaneous scleroderma. So it's not just in progressive systemic sclerosis, as it's still called in Southeast Asia. It is present both in diffuse scleroderma and limited cutaneous scleroderma. Autoantibodies like inflammatory myopathy play a very, very important role. Here is the data from Chris Denton in London. Here are the proportion of patients on y-axis that develop extensive pulmonary fibrosis. It is the anti-SCL70 or anti-topoisomerase antibody that helps determine whether you will develop progressive or significant ILD. Here are the light green and the dark green are limited and diffuse scleroderma distribution, but it's an autoantibody that predicts who will develop progressive ILD. The other aspect in this figure is that almost everybody who developed significant ILD developed in the first five years of onset of disease. So the take-home message is when you see a patient with scleroderma, do an HRCT, and I will walk you through how I treat these patients. But autoantibodies play a very important role that you should think about treating aggressively. When you do a PFT in a patient, and if you do a complete PFT with DLCO, in 27% of the patients, it will be false negative. In other words, it will be absolutely normal. And indeed, the patient will have definition, or they meet the definition of interstitial lung disease. At Michigan, we do a prone imaging. Not many centers do it, and I'll tell you why we do it. This is a patient of mine who has these early changes at the bases. We turn them around, we make them lie on their belly, and they continue to have these early interstitial changes. Where here's a patient who had these changes, they turn around, and those changes are due to gravitational pulls and other aspects, and these changes go away. So that's important to me to see how I follow this patient. This patient, even if I choose not to treat, I will have a very close follow up. This patient, I would be reassured both for myself and for the patient that the patient does not have ILD. There are guidelines, there are consensus highlighting that every patient with early scleroderma should have an HRCT. And the decline happens in the first 4 to 6 years. So that's why role of a rheumatologist, rather than saying, I don't know what to do for you, a better approach for a scleroderma patient is make a diagnosis, PFT, HRCT, and echocardiogram in every patient at baseline visit. So this is how I approach it at Michigan. Do you have ILD on HRCT? No. Early disease, there's a risk of ILD in the first 5 years. We continue to have a close follow up every 4 to 6 months in the first 3 to 5 years. Do they have ILD on HRCT? Yes. Is it a little bit or is it a lot? If you do HRCT on every patient, most of our patients have a little bit of ILD because most of them are coming asymptomatic. Do they have mild ILD on HRCT? Is their lung function normal? Are they symptomatic? No. In the past, we did not do anything for them, but I will show you data from a Tosalizumab trial and the Chris Denton cohort. If they have anti-topoisomerase antibody or SCL70, they are at a very high risk of developing progressive ILD. I would treat them. Whether you treat them with cytoxin, mycophenolate, I would not just sit around and wait for them to go from 90% to 70% before you treat them. Like I highlighted before, you're missing a window of opportunity, a window of therapeutic opportunity to treat these patients. The second cohort is moderate to severe ILD, FVC, desaturation symptoms. And if I ask all my colleagues, rheumatology colleagues in Pakistan, they will say, well, we don't believe in this data. Most of our patients, when we treat, are coming with clinically meaningful ILD. That's 90% of the cohort. Now, there could be two reasons for that. There could be genetic predispositions, genetic susceptibility that's different in Southeast Asia compared to US, but I don't think that's the case. I go to India on an annual basis and I give these lectures and see patients there still. I go there and see patients, help my colleagues to take care of scleroderma patients. I think the bias out here is that majority of the rheumatologists are not doing HRCT till the patients are symptomatic. So you're missing this big opportunity to capture these patients here and treat and start some treatment here. So we tend to use mycophenolate mofetil. This is our paper I was part of as a trainee at UCLA at this time. Here I am. This is mycophenolate was cytoxin, and it really changed how I practice. And here are the patients both on cytoxin and mycophenolate treated early on, and they actually had an improvement in the lung function. The key thing with mycophenolate is you have to go up to 3 grams per day in divided doses. So start 500 milligram twice a day for 2 weeks, 1000 milligrams twice a day, and then 1500. And if they get GI toxicity, take it with food and slowly increase it. So mycophenolate mofetil, we talked about cytoxin should be fine. If you use it, rituximab for rescue therapy, you can tend to use Imuran. We don't use Imuran much, but if you have Imuran, you can use that. And I'm not talking about the stem cell transplantation and the lung transplantation today. Here's an interesting article from India, from Kolkata, where they took patients who had diffuse scleroderma with ILD, anti-topo-1 antibody or SCL70, disease duration of less than 3 years, and they're treatment naive, perfect patient. And what they showed here was very interesting: targeted biologic therapy, randomized to rituximab, 1000 milligram, two doses. And you see this improvement in the lung function. 61 to 67 in person predicted 1.51 to 1.65 in the FEC litters, whereas they're stable cytoxin. So in the right subgroup, if the patient can afford it, you may even consider giving them rituximab as a first-line agent for the management of their underlying ILD. Once you commit somebody on immunosuppressive therapy with scleroderma ILD, it's a long-term commitment. Unlike rheumatoid arthritis, unlike inflammatory myopathy, it's not a lifelong commitment, but it's a long-term commitment. I treat them at least for 5 years, but I tell them upfront that if we stop the drug, the patients are on that for 5, 6 years. They are saying, well, we are doing great. Do we really need to continue taking this immunosuppressive therapy? And the question we need to tell them is that there's a risk of 20 to 30% of ILD in skin. And I see it all the time. One in 1 in 5, 1 in 6 patients do flare once we stop their immunosuppressive therapy. So here's a attorney. She is a he's a law professor at University of Michigan. Comes to me with new onset Raynaud's phenomenon, anti-topoisomerase antibody, puffy hands, no diffuse scleroderma. I do HRCT. I see these minimal interstitial markings at the bases. His C-reactive protein is elevated and FVC DLC are 80 to 180%. Would you treat this patient? He has no diffuse scleroderma, no previous PFT, no shortness of breath, pretty active 51-year-old person. So I'll show you our data on the Tosalizumab trial. And the Tosalizumab trial, or Actemra, randomized patients who had progressive skin disease, diffuse scleroderma, elevated CRP to Tosalizumab and placebo. The primary outcome measure was skin score that was negative, but what we showed was that if a patient who we consider quote unquote have normal PFTs, about 64% of these patients with early diffuse scleroderma had evidence of interstitial lung disease on HRCT. And when these patients are treated with placebo, remember our algorithm, when these patients with early diffuse scleroderma, topo-1 and or elevated CRP are treated with placebo, on average, they had about a 8%, excuse me, 8% decline in their lung function over a period of 48 weeks. 8% decline. Whereas patients who were treated with tocilizumab had this beautiful stabilization of their lung disease. So we have a window of opportunity in patients who have very early diffuse scleroderma, elevated CRP, or positive anti-SCL70 antibody. Based on this data that was published in Lancet Respiratory Medicine, we can provide them tocilizumab. The FDA is reviewing this right now, and we are hoping to get approval of tocilizumab for early scleroderma ILD in the next month or two. So here what I see with the tocilizumab can be used in ILD, early scleroderma, anti-topoisomerase antibody, elevated CRP, and early ILD on HRCT. Again, I understand in Pakistan you have to pay cash for the drugs, but there may be well-to-do patients out there who may prefer to take tocilizumab based on the striking data than go with mycophenolate or other treatments. I understand also that nintedanib is not available in Pakistan for management of lung fibrosis, but I want to share some data. I'm sure it will be available soon. Nintedanib is a tyrosine kinase inhibitor that targets important receptors that are important in fibrotic ILDs. And here is the data from my colleague, Oliver Distler in New England Journal of Medicine, where they took patients. Now here I'm talking about patients who are symptomatic, patients who are coming to you with scleroderma, they're short of breath, they are both limited and diffuse scleroderma. 50% had diffuse scleroderma, FVC percent predicted was 72%. So your typical patient, 30% lung fibrosis on HRCT, your very typical patient. Half the patients were on mycophenolate. They were started on nintedanib or on placebo. And what you see over a period of 1 year, the patients who were on nintedanib had a less decline compared to patients who were on placebo. And here they are showing the proportion of decline in the nintedanib and placebo. So that's what we do in practice today. We start people on with scleroderma ILD that is significant ILD on mycophenolate. And if they're not responding, they're getting increasing shortness of breath, the FVC is declining, we tend to add nintedanib to the management of their disease. Here's the data with background mycophenolate, and it seems like that it's synergistic compared to taking as monotherapy. Once you start using nintedanib, there's a lot of GI side effects and tolerability issues. So I will not go over that because you don't have it available, but diarrhea, nausea, vomiting. So you have to educate patients about these things. And it makes it difficult in a patient population that already has GI dysmotility. So I will skip this slide regarding nintedanib. So this is how we treat people. A patient comes, they have subclinical ILD, a little bit of ILD, HRCT on every patient, low risk of progression, close follow-up, anti-centromere antibody, limited scleroderma, follow them up every 4 to 6 months. High risk phenotype, early diffuse scleroderma, anti-topoisomerase antibody, elevated acute phase reactant. If you're fortunate to get tocilizumab, but the key take-home message here is that I would not leave them alone. I would add something at that time. I will not wait. You should not wait for the lung function to get abnormal, the patients to get symptoms before you treat the patient. That is the take home message of this slide. If you do have clinical ILD, and again, you don't have nintedanib, but we tend to go to MMF. So you have clinical ILD, the patient comes to you, they have limited scleroderma, no skin or musculoskeletal significant issues. I would still treat them with mycophenolate mofetil. If they have active skin and musculoskeletal disease, of course, mycophenolate mofetil, and if they're worsening, we tend to add rituximab and nintedanib. A very important take-home message that I did not highlight, scleroderma ILD is an earlier complication of scleroderma. Number two, most of the loss in the FVC occurs in the first 5 to 6 years. This algorithm is not appropriate if somebody came 15 to 20 years after starting of their scleroderma and they have significant ILD. Once the lung fibrosis has burnt out, it usually does not get progressive. There are exceptions, of course, in medicine, but this algorithm is for early scleroderma with interstitial lung disease. This algorithm is no longer valid when they're 7 to 10 years to 15 years um, onset of their systemic sclerosis. Worsening of lung fibrosis in a patient who has a long-standing scleroderma is likely due to aspiration. So you have to look at the esophagus, you have to look at the size of the esophagus. Every scleroderma ILD patient, every ILD patient, apart from getting the influenza vaccine, pneumococcal vaccine, should always be sleeping at an angle. They should always be sleeping at an angle so they're not aspirating at night. If you do offer transplantation, here's the data. While I was at UCLA, lung fibrosis and scleroderma patients have a 5 year survival of 50%. So now comes an important concept for our pulmonologists, what rheumatologists can teach the pulmonologists, medical students, and fellows. I told you that 15% of IPF patients subsequently are diagnosed with CTD lung fibrosis. Education, what are the symptoms? And I will not belabor over the symptoms. We are all rheumatologists listening to this talk. What are the signs? Raynaud, CTD associated rash, swollen joints, anti-nuclear antibody. And I just want to highlight for a non-rheumatologist that low titer ANA is seen in IPF. It comes to common sense that 40-year-old people do not develop IPF. So we tend to look for, is it multi-compartmental involvement? Is there a dilated esophagus? Is there pericardial thickening that may um, make us, it's a clue that there's an underlying lupus and Sjogren and other things that are going on. Is the pattern not UIP? IPF is a UIP pattern. This is one of the last slides, and there's a term or there's a new classification called interstitial pneumonia with autoimmune feature. And these are the patients which you and I used to call or still call undifferentiated connective tissue disease. So they have a serology that may be positive for rheumatoid arthritis. They have a rash. They have Raynaud's phenomena. There's something going on that is not pure idiopathic pulmonary fibrosis or idiopathic NSIP. This is our unpublished data. It is still in press. This was presented by Eric White, who's a pulmonologist. And I want to go over the survival here in our cohort over a period of 120 months. So you can see we have a very big IPF population of over 1,000 patients, and you see the survival of the IPF over 120 months or 100 months is about 30%. So again, IPF is a terrible disease to have, and once you diagnose IPF, you're looking at a 100-month survival of approximately 30%. We had patients who had IPAF and CTD similar proportion, and you see them. This is the IPAF, the red one, and the blue one is a CTD. And I just want to show you the survival and the overall outcomes in the undifferentiated or IPAF population is similar to the CTD population. And in our cohort, 16 to 17% of the patients who had IPF undifferentiated over time developed into a definable, classified connective tissue disease associated ILD. So it's important again for a rheumatologist when you get a consultation from a pulmonologist, make sure you look for the clues in the autoantibodies, nail fold capillary changes, mechanic hands, rash, um, multi-compartmental involvement with pericardial thickening and other aspects that may clue you that this patient may have undifferentiated connective tissue disease, and you're able to start a immunosuppressive or a immunomodulation in this patient. So this is my last slide, screening HRCT in all patients with scleroderma early. Early inflammatory myopathy if you're fortunate to find somebody with anti-MDF5 or anti-synthetase. So I'm requesting everybody when you make a diagnosis of elevated CPK and inflammatory myopathy, order a myositis panel. That may be the difference between a patient surviving and dead. Unlike scleroderma ILD, which is a slow progressive disease, inflammatory myopathy is very progressive, dramatic decline in the lung function, intubated and extubated within a week of giving prednisone. Corticosteroids and immunosuppressive therapy are important, the exception being scleroderma ILD. There's no role of prednisone here. If you want to give prednisone, you can give 10 milligrams a day if that makes you feel good, if they have musculoskeletal involvement, but there's no role of corticosteroids in the management of scleroderma ILD. All these are important corticosteroid immunosuppressive management in early scleroderma ILD, not in the later one. Rituximab for resistant ILD, nintedanib, if it's available, I can come back and we can do an hour lecture on anti-fibrotic therapies. There is some data on abatacept and tofacitinib. So think about a patient with COVID era, a patient who has scleroderma or rheumatoid ILD, and you want to give them something for their joints and ILD. You do not want to put them on rituximab that may have a half-life of weeks. You can put them on abatacept in this case scenario, and I've done that with a few patients at Michigan. If you do see a patient with progressive RA-UIP, they're not responding to rituximab and other therapies, I think that patient is unfortunate, a candidate for lung transplantation. I thank you very much, and I hope you have a wonderful RheumCon 2021. And again, I appreciate the invitation. Thank you very much.